Hello and welcome. Today, we're diving deep into the science behind a class of drugs that millions of people encounter every single day, antidepressants. We're going to explore how they work, the theories behind their development, and what the future might hold for treating depression. So let's get right into it. To really understand the drugs, we first have to get a handle on the condition they treat. And depression is so much more than just feeling sad. It's an extremely common psychiatric condition, and in fact, it's a leading cause of disability across the globe. Tragically, it can also lead to premature death, not only through the risk of suicide, but also because it increases the likelihood of dying from other illnesses. And here's the real challenge, the thing that drives this entire discussion. For as common as depression is, our understanding of what's actually going on in the brain, its neurobiology, and how these drugs truly work is, well, it's still surprisingly limited. All right, so here's our game plan for this masterclass. First, we're going to get a really clear picture of what clinical depression actually is. Then, we'll dive into the core hypothesis that has shaped almost all the drugs we use today. That's the monoamine theory. From there, we'll walk through the major drug classes, starting with the modern SSRIs and SNRIs, then looking at the older TCAs and MAOIs, and we'll finish up by looking at the exciting new frontier of atypical and rapid-acting drugs. So, first things first, what exactly is clinical depression? Let's get really clear on the key distinctions and the symptoms. Okay, it's absolutely crucial to distinguish between two main types of depressive syndromes. On the left, you've got clinical depression, which you'll also hear called major depressive disorder. The key thing here is that the mood changes are always in the same direction, down. This is by far the most common form. We're talking about 75% of cases, and it's often associated with stressful life events. Then, on the right, you have bipolar disorder. This is different because the depression alternates with periods of mania, a state where a person's mood and actions can seem really inappropriate for the situation. For the rest of this discussion, we're going to be focusing squarely on that first category, clinical or unipolar depression. So let's break down the symptoms, starting with the emotional ones. And these go so much deeper than just sadness. We're talking about a persistent low mood, an onslaught of negative thoughts, a sense of misery, apathy, and deep pessimism. There's often a huge drop in self-esteem, which brings on feelings of guilt, inadequacy, even ugliness. Indecisiveness and a complete loss of motivation are also classic signs. And then there's this really important term, anhedonia. Anhedonia is the loss of interest or pleasure in things that you used to find enjoyable and rewarding. It's a core feature of depression. And beyond that heavy emotional toll, depression has very real physical, biological symptoms. This can include a slowing down or retardation of thought and action, which can show up as memory problems. A loss of libido or a low sex drive is also very common. And even our most fundamental functions like sleep and appetite can be profoundly disturbed. So what brings all this on? This diagram really lays out the modern view pretty well. It's a combination of things. Over on the left, you see the risk factors that create a sort of vulnerability. This comes from our genes, but also our environment, things like adversity or trauma in early life. These experiences can cause what are called epigenetic changes, which is a fancy way of saying they can alter how our genes are expressed without actually changing the DNA code itself. But, this vulnerability usually isn't enough on its own. It's when it gets combined with what we call precipitating factors, things like psychological stress or physiological stressors like a chronic illness, pain, or inflammation, that the disorder can actually manifest. All right, now that we have a better definition of the condition, let's move on to the central theory that has guided antidepressant development for decades. This is the monoamine theory. Now, this is where the story gets really, really interesting. As a complete, all-encompassing explanation for depression, we now know the monoamine hypothesis is insufficient. It's just too simple. But, and this is the absolute key point, pharmacological manipulation of these monoamine systems is still the single most successful therapeutic approach we have for treating depression. This diagram shows the theory perfectly. Let's walk through it. A synapse is just that tiny gap between two nerve cells where they pass chemical signals, called neurotransmitters. So panel A shows a normal, healthy synapse. You see the monoamine neurotransmitters, like serotonin, being released from one neuron, crossing the gap, and then being taken back up in a kind of recycling process called reuptake. Now look at panel B, which represents the depressed state. The theory goes that there's a decreased amount of these monoamines floating around in the synapse. And finally, panel C shows the treatment. Antidepressant drugs work by blocking those reuptake sites. What does that do? Well, it means the monoamines hang around in the synapse for longer, which increases their concentration and hopefully restores normal communication between the neurons. That reuptake mechanism we just saw is the primary target for our most common modern antidepressants. So let's look at the two main classes that work this way, the SSRIs and the SNRIs. First up, we have the SSRIs. That stands for Selective Serotonin Reuptake Inhibitors. And as that name suggests, they're pretty specific in what they do. This table gives us a great snapshot. You can see some common examples there like fluoxetine and citalopram. The mechanism is exactly what we just discussed. They inhibit the reuptake transporter for serotonin. Now, a really critical point for anyone taking these is the time frame. It typically takes a good 4 to 6 weeks to really feel the full therapeutic benefit. Their side effects are generally milder than the older drugs, and this is a big one, they are much, much safer in an overdose. That's a key reason why they are the most frequently prescribed class of antidepressants today. But there's one very serious interaction you have to know about. If you combine SSRIs with an older class of drugs called MAOIs, which we'll get to soon, you run the risk of a potentially fatal condition called serotonin syndrome. Okay, next up are the SNRIs. The name pretty much gives away the key difference, serotonin and noradrenaline reuptake inhibitors. So instead of targeting just one neurotransmitter like the SSRIs do, these have a dual action. They inhibit the reuptake of both serotonin and noradrenaline. They also take about 4 to 6 weeks to work, but because they mess with noradrenaline, their side effect profile can be a little different. They can sometimes cause an increase in blood pressure, sweating, or headaches. A really interesting clinical advantage here is that this dual action can also make them effective for treating certain types of pain, like neuropathic pain. And just like the SSRIs, they carry that same risk of serotonin syndrome if they're combined with other drugs that boost serotonin levels. So before we had the development of SSRIs, the mainstays of treatment were two older classes of drugs, the tricyclic antidepressants and the monoamine oxidase inhibitors. They are generally less specific in their action, and that means they come with more significant side effects. First, let's talk about the tricyclic antidepressants, or TCAs. Now, like the SNRIs, they do inhibit serotonin and noradrenaline reuptake, but they're much, shall we say, dirtier drugs. They also block several other receptors, and that's where all their side effects come from. So, blocking muscarinic receptors causes atropine-like effects. Think dry mouth, blurred vision. Blocking H1 histamine receptors leads to sedation, which is why they can make you drowsy. And blocking alpha-1 adrenergic receptors can cause something called orthostatic hypotension. That's a sharp drop in blood pressure when you stand up that can make you feel dizzy. But the most crucial point here is that they are extremely dangerous in overdose. We're talking cardiotoxicity, coma, and seizures. Because of this scary risk profile, they're now reserved for specific cases, like treatment-resistant depression. And they interact with a lot of other drugs, with the number one rule being they absolutely must not be given with MAOIs. The second class of these older drugs is the monoamine oxidase inhibitors, or MAOIs. And these guys work in a completely different way. Instead of blocking that recycling pump on the outside of the neuron, they block an enzyme on the inside of the neuron that's responsible for breaking down the neurotransmitters. So the end result is the same. More monoamines are available for release, but the mechanism is totally unique. And it comes with its own unique set of problems, most famously a very dangerous interaction with certain foods. Let's break down that dangerous cheese reaction step by step. It's a clear chain of cause and effect. First, the patient is taking an MAOI drug, so the enzyme monoamine oxidase is inhibited all over their body. Second, they eat a food that's rich in a substance called tyramine. Think aged cheese, certain cured meats, or some red wines. Normally, the MAOI enzyme in your gut and liver would just break this tyramine down, but since it's inhibited, tyramine gets absorbed right into the bloodstream. Third, that tyramine makes its way into nerve terminals and causes a massive, uncontrolled release of noradrenaline. And the final, dangerous consequence, a severe hypertensive crisis, a rapid, huge spike in blood pressure that can be a full-blown medical emergency. All right, let's move into our final section, where we're going to look at some drugs that don't fit neatly into those other categories. These represent the new frontiers of antidepressant pharmacology. Okay, let's start with a drug called mirtazapine, which has a really fascinating mechanism. Instead of blocking reuptake pumps, it basically works by cutting the brakes on the neuron. It blocks these special presynaptic receptors called alpha-2 autoreceptors, which normally act like a brake, telling the cell to stop releasing neurotransmitters. By blocking this brake, it actually enhances the release of both noradrenaline and serotonin. And this totally different mechanism leads to a very different side effect profile. It causes less nausea and sexual dysfunction than SSRIs often do, but it frequently causes weight gain and an increased appetite. This can actually be a good thing, making it useful for patients who need help improving their sleep and appetite. Now, before we talk about our next drug, we need to define a really key term: treatment-resistant depression, or TRD. An individual is considered to have TRD if they've tried at least 2 different antidepressant treatments during their current depressive episode and neither of them has worked. This is a huge clinical challenge, and it's what really drives the search for brand new therapy. And this brings us to one of the most exciting developments in this field in years, the rapid-acting antidepressants, or RADs. Remember how we said most antidepressants take 4 to 6 weeks to kick in? Well, these can have effects much, much faster. A key example is esketamine, which is marketed as a nasal spray and was approved specifically for treatment-resistant depression. Its main mechanism is as a non-competitive NMDR blocker. This receptor is part of the glutamate system, a completely different neurotransmitter system than the monoamines we've been talking about. What's so fascinating and frankly so complex is that other drugs that block the NMDR, like memantine, have actually failed in clinical trials, and to make it even more puzzling, a totally different drug, the muscarinic antagonist scopolamine, has also shown rapid antidepressant effects. So there's a lot we're still figuring out. And this really brings us to a massively important takeaway from all this. The discovery of these rapid-acting drugs is about more than just a new treatment option. It's providing a completely new avenue for research. It's forcing scientists to look way beyond that original monoamine hypothesis and explore totally different pathways to try and truly understand the fundamental biology of depression. So, we'll end with this final thought. We've gone on a journey from the basic definition of depression, through the decades-long influence of the monoamine theory, all the way to the very latest treatments that are starting to challenge that theory. The crucial point is that our understanding is constantly evolving. And that leaves us with a big question for the future. What incredible new treatments might emerge as our understanding of this complex condition finally moves beyond the monoamine hypothesis?